Hello and welcome to Two Peds in a Pod, the paediatric medical education podcast. Remember, you can hear our entire back catalogue of episodes on iTunes, Spotify, Google Podcasts, Amazon Music, and of course, our SoundCloud. So please tell your colleagues and friends and hit that subscribe button. I hope you enjoy today's episode.
Welcome to another podcast from Two Peds in a Pod. It's Ashey Reece hosting. I'm a consultant paediatrician. I work at West Hertfordshire Hospital's NHS Trust with another new voice to the podcast. And it's great to be here talking about medicines and children with Sumiah.
Thank you, Ashley. I'm Sumiah Al-Azeib and I'm the lead pharmacist for women and children at Medway Hospital in Kent. And it is a pleasure. This is my first podcast, so kind of looking forward to it. Thank you. And we will be talking about paediatrics and medication in general and prescribing.
Prescribing medicines for children, it's quite a different situation, prescribing medicines for the paediatric population compared to adults. So let's start by thinking why that is.
Well, initially, if you think about paediatrics, it can be anything from a little neonate or a premature baby up to 18 years of age. So you might get a 500-gram baby up to anything over 100 kilos. Dosing as well is not standard in adults. Dosing is, for example, 1 gram TDS. In pediatrics, it will be based on milligram per kilo. It can be age-banded or it can be both age-banded and mixed per kilo. So there's more potential for errors and missing the right dose, especially if you're not looking properly or checking the BNF properly. Pharmacokinetics in children is evolving, so a neonate's absorption or distribution is completely different to an older child or a 10-year-old child or a teenager that will reach at adult levels. Also, we are prescribing or using a lot of unlicensed medication and off-label medication, which we don't tend to use in adults. So the data might not be readily available. We have lots of specials that we use that have different standards, so the strengths are not the same.
Can you give us some examples then of those situations where there are issues with different strengths of the same medication?
I know at a previous trust that I worked, we had a little girl that was prescribed propranolol, and she was dispensed a 5 milligram and 5 ml bottle from our trust. She went to another hospital and then she was dispensed a 50 milligram in 5 ml. So it was 10 times more concentrated. Unfortunately, parents don't always pay attention to the strengths. They don't always pay attention to what's written on the label, and they just gave the same dose in terms of mils. So that she received a 10 times overdose and ended up in A&E, unfortunately. Another example as well is a liver transplant child who was booked in for a biopsy query rejection and who was on tacrolimus liquid. So from the hospital, they were dispensed a 1 milligram in ml oral solution, whereas in the community, they received a 0.5 milligram in ml, which is half the strength, basically. This only transpired when we carried out the meds reconciliation, and then we found out they were only receiving half the dose that they should have been receiving. Biopsy was cancelled. We changed them over to a licensed preparation of tacrolimus. And yes, so there are lots of issues that can occur with pediatrics and medication. It's not as straightforward as the adult population, I'm afraid.
You mentioned unlicensed medication. So there's a medicine that we start in hospital that needs prescribing, there needs to be a repeat prescription, and with all respect to our colleagues in primary care, they feel unable to do that. So what's happening there?
Yeah, so a lot of the time the CCGs actually kind of stop them from prescribing unlicensed medications. Some GPs will still prescribe it and they're happy to support. Others feel uncomfortable or uneasy about using unlicensed medication. This obviously has an impact on continuity of care because and it affects the patients and the parents because they end up going back and forth between either the specialist centre, the GPs, sometimes coming back to the local hospital, which might take on the prescribing just to facilitate. So it can be a little bit frustrating, I can imagine, for the parents, especially when they have so much to worry about already.
Why is it the CCG is not happy to prescribe the unlicensed medicine?
Well, they have a formulary and they stick to it, and usually unlicensed preparations are out of limit. They're not in that formulary.
Yeah, they appear in the BNFC as medications with an indication, and they would seem in that way to be appropriate and safe.
I think the main issue that I see is when they create these formularies, paediatrics are not necessarily thought of, so it really depends where you are exactly. It might be acceptable in some areas, but not everywhere, so that's something that really needs to be looked at.
So we could lobby the CCG and the pharmacy team in the CCG and say, look, here's some medicine prescribed regularly. Here's the data that we've got on safety. Here's its monograph in the BNFC. Could we include it in the local formulary so our GPs can prescribe it, and our families don't have to, get a prescription from secondary care every 2 or 3 months?
That would be ideal. That's something that I'm also looking at, to kind of set up a separate paediatric formulary, even though it's in the BNFC or in different, paediatric resources. I think it has to be specific to the local CCG and discussed with that CCG. But it's definitely needed because children seem to be an afterthought sometimes, I feel. So, yeah.
So we mentioned the BNFC, which is obviously the British National Formulary for Children, and there are that's the main sort of go-to Bible for our prescribing now. And the British National Formulary for Children, the version of the BNF, has been around for children for quite a few years. But there are a number of other formularies around, and I had an Alder Hay one back in the day. And there's the Guy's formulary, and they used to prescribe slightly differently or give the doses slightly different ways, I seem to remember.
Yeah.
So that engenders more confusion, doesn't there, for the prescribing?
Sometimes, yeah. Well, the BNFC is actually becoming more and more comprehensive, so there is definitely more information now that you can find in the BNFC. Sometimes the Evelina's formulary, you can find maybe a little more, some drugs that you may not necessarily use, or very specialist drugs, and it has nuggets of information as well. The Alder Hay, I don't know if they still have one, to be honest, but I do remember they had an old one, which was quite useful. But I think the BNFC / Evelina formulary should contain practically everything. All the medication that we use.
Of course, the great thing about the Alder Hay book was it fitted in your pocket. But of course, with the BNFC being available electronically these days, that's less of an issue, isn't it?
Yeah, it's easily available on the app. It might be more difficult to see on the app, to scroll through. And I think what we have to be careful of is there's so many different sections for each drug. So, there might be different indications, different routes. And I've seen people make errors where they just go and select the first dose that they see, regardless of route. So they might want to prescribe an IV route, but then they go and select the dose for the oral route, or the wrong indication, so the doses might be suboptimal. So we have to be careful and just make sure that if we're looking at the app, we're scrolling through the whole section just to make sure we're not missing the bit that we need to prescribe.
When you mentioned earlier on, there's doses sometimes for weight on milligrams per kilogram, and there's doses that you've got for age bands, and sometimes if both are given for a given child, they don't always match up. So which is the right dose? Is there any indication of which one would be best in that situation?
I would say, for example, you might have an older child, but they weigh 30 kilos or whatever, something like that. You might have a 12-year-old child. So in those circumstances, I would calculate what the dose per milligrams is, just to be on the safe side that we're not giving, more than we should. So we always have to take that into account. It's the same thing with paracetamol or some thromboprophylaxis. If they're under 50 kilos, then we can't just go by age. We have to dose it by weight. And this happens in adults as well. The other way around is you might have bigger children, so adolescents, and you're dosing mix per kilo, but we always have to cap it at the adult dose. So we just need to make sure that we're not exceeding the adult dose, or we're using the ideal body weight, which might be mentioned in the BNFC. So we just need to check what the guidance is for that dosing.
Okay, so for some medications, it's important to dose using surface area, and there's a surface area chart at the back of the BNFC, isn't there?
Yes, lots of people think they need to do a calculation or use some kind of fancy formula to calculate the body surface area, but it's actually at the back of the BNFC, or you can it's on the app or online. If you go to guidance, there is a section on body surface area, and you just look at the corresponding the weight and then the corresponding body surface area. So examples for this would be acyclovir, that's normally used for children from 3 months up to 12 years of age. It's dosed by body surface area. Caspofungin, which is an antifungal, can also be dosed by body surface area, and obviously chemotherapy as well. So it's not many drugs that we would dose by body surface area. But ideal body weight, for example, vancomycin or some neurotherapeutic drug index drugs, we need to use ideal body weight. We can't just use, if we have a 100 kilo child, we can't just give gentamicin 7 milligrams per kilo, which gives us 700 milligrams. We will have to use ideal body weight. Otherwise, it can cause renal impairment or other toxicities. So we just need to be wary.
And that's a really important point, isn't it? Because the maximum dose for some of the medications, if it is calculated using the child's actual body weight, you will get well over the maximum. And that's obviously the source of many medication errors. So checking the maximum, particularly in older children, is really important.
Yeah. I think if you're exceeding the adult dose, if you're familiar with adult doses, you need to stop and think, what, am I doing the right thing? Just go back and check. Also, I find this is just sometimes junior doctors prescribe things that they're not really sure about, which is a little bit worrying. So they may prescribe something, it's not spelt properly. You go and ask them, oh, what do you mean by this? Oh, I was just told to prescribe that. So everyone, whatever you prescribe, it's your responsibility. You need to check that the name is correct. You need to check that the indication, there is a proper indication for that, and that the dose that you've been told as well, because parents can get confused as well and can give you the wrong doses or mix up doses between drugs. So just make sure before you prescribe anything that the dosing is correct, and the indication as well is correct, and the name.
So that's another important point, isn't it? When we're talking to parents, they'll often tell you how many mils of a drug they give. And we've mentioned already that the preparation that the drug comes as, particularly liquid medications, where milligrams per mil, we need to check back and make sure we know the strength to make sure that it's the right dose of the medicine.
Yes, and ideally, in the prescribing standards, we're not supposed to prescribe in mils because of the issues of the various strengths available. Obviously, there are exceptions. So, for example, vitamins like Dalavit, Abidec, or iron like Citron or ferrous fumarate liquids will prescribe those in mils. And for example, Coamoxiclav, but we'll have to specify the strengths, obviously, for those. Yes, mils, sometimes when you go and speak to parents and you say, is it milligram or mil? They have no idea. I don't think they understand the concept of mils or milligrams, to be honest. So it's better to check the bottles, if they've brought it in. If they haven't, I would normally get them to call someone at home and double check or take a photo. If it's prescribed by the GP, we can check their summary care record. If not, then it's a little bit trickier. But it's just you need to ensure that you're prescribing the dose in milligrams. Because if you just prescribe in mils, someone can just go and pick up a bottle from either the ward stock or order a different strength, and they'll give X mils of another strength. So it could be underdosing, it could be overdosing, so it's really dangerous, and we need to prescribe it in milligrams, not mils.
And these days, it's very easy, isn't it? Often when I'm in clinic, somebody will text somebody at home or make a quick call, and while we're continuing the consultation, they'll often get back the picture or the information about exactly what the strength is of the medicine that's at home. Now, you mentioned prescribing standards. So tell us about the prescribing standards and where we might find those.
So if you look at the BNFC at the front section, there are a few little sections about different types of guidance. So one of them is prescribing standards. So it just tells you, for example, it's a legal requirement to have the age of the child if they're under 12 years of age. You need to have the weight. You don't prescribe in mils, as we've already mentioned. It encourages leading zeros. So, for example, 0.6 instead of 0.6 milligrams, because 0.6 milligrams can be read as 6 milligrams, but ideally it's better to write that as 600 micrograms. And on the opposite as well, it's to avoid trailing zeros. So 5.0 milligrams can be read as 50 milligrams if that dot is really faint. Obviously, write the units in full, so micrograms, nanograms, milligrams, we just write mg. And then also to prescribe generically. You would only prescribe by brand name if there's some kind of bioavailability issue. For example, for immunosuppressants, tacrolimus, you would prescribe it by brand because it will affect the levels. Some anti-epileptics as well. So those are the main ones, really. But people can refer to that. Just go to the front of the BNFC and you can check that over there.
Yeah, it's a great resource actually, and should be at the forefront of everyone's mind. Of course, our doctors in training these days do a prescribing safety assessment just before they take their finals, so they cannot progress to their foundation year one without passing that test, or actually they can, but they may need to do a resit. And then many trusts do their own local prescribing test as well, just to make sure that nobody's forgotten anything since they did the PSA test.
Yeah. I mean, I think it's good that not all trusts, unfortunately, but it's good if prescribing tests are conducted, because it just makes the doctors think, or even advanced clinical practitioners as well, just stop and think, oh, what should I be doing? Am I doing the right thing? And then when you go through the test with them as well, it kind of highlights the areas where they should have, where they went wrong or could improve as well.
And our allied health professionals have supported a number of nurses through their independent prescribing course. And they go into great detail of the medicines that are going to be the ones that they might commonly prescribe. And they have to do a fair bit of basic clinical techniques, so history taking and examination.
Yeah, they do, yeah. Because I think, the whole idea is to equip people or advance their skills as well, to enable them, because it's not just prescribing. They need to look at the patient as a whole and examine them and, justify why are they prescribing this? Are they completely convinced? Is it the right drug?
Okay, you mentioned branded medicines earlier and how we prescribe generic, not branded medicines.
Yeah.
One of the things that we often suggest to parents is that they get over-the-counter medications for children, and in any family, locked cabinet away from any children, keeping them safe and secure. There's often a sort of family of medicines. There's often a number of bottles of different medicine there that you would need. So some antipyretic and maybe some antihistamine and those sorts of medicines. They can be bought over the counter, but if you buy a branded version, they're often more expensive than a generic non-branded version.
Unfortunately, that's the case, yeah. Usually when a drug comes out onto the market, it will have a patent for X number of years, and they will have the monopoly, to sell that drug, basically. Once that comes off patent, then all the generic companies can start producing it. But most of the time, the branded ones will still be more expensive, and some people, believe that the branded one is much better quality and it's more effective, but that's not necessarily the case because they all undergo rigorous kind of testing and quality assurance. Branded ones should only be specifically if there is a bioavailability issue or a specific formulation that's only suitable for a particular patient group, for example.
Now, we mentioned a lot about liquid medicines, and children obviously will usually anyway take a liquid medicine, although sometimes that's a challenge depending on the taste, and some of these medicines taste actually really okay, and some of them are quite frankly quite foul. But there's an assumption that younger children cannot take tablets or cannot swallow tablets. So I know there's quite a lot of information out there in order to try and support families in teaching their children how to take a tablet at a young age. What's your experience of young children? I'm thinking of even preschool children being able to take a reasonably sized tablet.
So it does vary. There are some older children or even adults I've seen that will refuse to take tablets and just want liquids. They can't swallow. But then you would see younger children that can swallow a tablet easily. So, sometimes I wouldn't be expecting them to be taking tablets, and yet they would prefer the tablets to the liquids, because sometimes some of the liquids tastes a little funny, like you mentioned, and they don't like the taste. It might make them gag. So yeah, I don't think age is a barrier, and there is an information leaflet or teaching as well, a training for kids medication to teach children how to swallow pills or tablets, which is quite useful. Different techniques to try out. So, and some children see it as a challenge as well, that I can swallow this. So it varies, yeah. But I think we should encourage children.
One of those resources is called KidsMed, isn't it? KIDZMED.
So that was by Newcastle, and they did, teaching basically for children different techniques of how to swallow tablets, which is really quite good. So it's even for health professionals. They can go and check it. It's on the e-learning website on HEE. It's useful for everyone, really.
So it's out there on the Electronic Learning for Health platform. So before we close and round off maybe with some take-home messages, one final thing is about patient safety, of course, because we mentioned that prescribing is one of those activities that, unfortunately is prone to errors. So we're going to get to patient safety in a minute, but I noticed that the pharmacist always writes with a green pen.
Yeah. Yes, they do. I think it's just historical, to be honest. I don't know if there's a rationale behind that. But many trusts are moving away from green pen because you can't really photocopy if you photocopy the notes or the drug charts, the color, it doesn't appear properly. But now with electronic prescribing in many hospitals, there's no green pen anymore. Some actually, I can't remember where, but I know there was one electronic prescribing system when the pharmacist screens the prescription, it comes up as green. The initials or the pharmacist screen shows up in green on electronically. So that's quite interesting.
Harping back to the old days. So thinking about patient safety, obviously prescribing has the potential for error, particularly when it's not done electronically. So what are the important issues around preventing medication errors?
I think the main one is distractions or interruptions, really, because that can happen, quite frequently on the ward environment. Also, we've done this where once the doctor has prescribed something, we ask the nurse to double check it immediately, and get back to the doctor if there are any issues, because if by the time the nurse checks it, it's an hour or so later, it might be difficult to get the doctor there. And then also not to interrupt the doctors. There's different strategies of just them sitting by themselves or in a little corner just to prescribe without being interrupted, just like when the nurses wear their tabards, for drug preparation and administration. And I think you had something to do with the druggle, I think.
Yeah, so I can lay claim to the name for our drugs safety huddle, which we affectionately call the druggle. But patient safety meetings around medication, so medication safety huddles or medication safety meetings, have been well described in the literature over time. So our version is a weekly meeting at the end of our grand round, 5 minutes, where the pharmacist comes and tells us the issues that they've picked up on their interventions on the drug charts in the previous week, and also gives the team some gems of good behaviour around prescribing, and then leaves us with a few pearls of wisdom information, things that they want us to know about what's coming up.
And did you find that helped, or were there recurring themes? Or
yeah, I think there's always issues that occur in cycles, and that usually maps to new doctors into the department because they're less familiar with prescribing medicines for particular patient groups. For example, children with long-term conditions that are on lots of medications potentially. So we do see that, and it's an opportunity to focus the team on medications and medication safety, because we have this episode where the senior pharmacist comes every week and talks about medications. So one of the most important impacts is having that time every week where we think about medication and medication safety.
That's really quite good that you're making time for that. So yeah, I think that's a positive thing, and it would be good if everywhere does it really.
The druggle itself, it's a cute name for something that's been around obviously. There are other units that have taken it up, and I believe even as far as Australia. So why don't we summarise then some of the important points that we've made around prescribing in paediatrics in order to summarise what those important take-home messages are.
All right. So the main things when you're prescribing, just make sure you check the age of the patient and the weight. Don't prescribe in males. Check the BNF properly for the correct indication, the correct route, and the dosing regimen that you're using. Don't prescribe by brand names unless really relevant for that. And always, when you're prescribing anything, you need to be accountable and know what you're prescribing, whether it's the dose, whether it's the drug name. So you are responsible for that prescription. And dosing wise as well, if there is a patient that's small for their age or obese, we need to as well take that into account, and we might have to use either ideal body weight or just dose based on their weight instead of their age if they're quite small for size. So
very helpful points, and I'll just add two things when writing a prescription: make it legible, and try not to be distracted while you're writing your prescriptions.
Yes, because that's when you start making mistakes and you don't know about it.
So are there any other useful resources out there that might be helpful for us when we're prescribing?
There's a useful website called medicinesforchildren.org.uk, which is very useful. It's child-friendly, and it's got general leaflets about medicines used in children, and also leaflets for medication as well. So it's in a child-friendly format instead of reading that small patient information leaflet with a small writing. It also has useful information whether you can crush the tablets or whether you can mix it with food or juice. So that's a useful website to go to.
So, Sumiah, I really enjoyed that chat, a bit of a tour there of prescribing and thinking about how we prescribe in paediatrics. It's a really useful way to spend half an hour or so and think about how we prescribe to make it as safe as possible. It's a really important part of what we do, and you gave some really interesting insights into how to do it better.
Thanks for taking the time to download our podcast this week. If you enjoy our podcasts, please tell your friends and colleagues and subscribe to us on Spotify, iTunes, Google Podcasts, Amazon Music, and of course our SoundCloud. Thanks for listening.